All right, we are absolutely excited to be back for another week of Women's Health Weekly. We are so appreciative of the YouTube viewers and our patients and their friends who have joined our live telecast. It's been a ton of fun. For those of you subscribing to the YouTube channel, you'll probably notice that we're doing a tremendous amount of uploads of videos. Mainly we're doing that because it's very obvious to me and obvious to everybody out there that absolutely nobody has the time to sit through a 40-minute video. Nobody wants to. I don't even want to. I don't have the attention span for that. So what we've done is we have a professional video team, and they are cutting up our videos into easily viewable clips of 5 to 7 minutes. It happens to be that 65% of the people that watch our videos are under the age of 34. So we really want to do our best to tailor both our content and our ease of viewing to those folks. So without me blabbering on anymore, I'd like to introduce my longtime colleague, Dr. Nikole Ostrov. Dr. Ostrov was the very first doctor to join me in Maiden Lane Medical. So we've been working together for what, Nikole? What are we talking about here?
Over 9 years.
Over 9 years.
Yeah, about 9.5.
And just to be clear, I've only been married 10. Oh, I've not even been married 10. So both relationships are lasting. It's pretty good. So Dr. Ostrov is amazing. And she comes from the very pure background of having one goal as a physician. She's a patient's doctor. And her goal is you to be educated, you to be well taken care of, for you to be healthy, and for you to stay healthy. And I am 100% sure that the information that Dr. Ostrov is going to offer us today is going to go in that direction. So what are we talking about today, just in general?
Birth control, contraception.
So, okay, so that's just a super broad topic, right? I mean, that is
very broad.
That has a lot of information to go around. We'll try to hit as many points as possible. As usual, we're going to take viewer questions throughout. We'll interrupt the conversation for viewer questions. We'll do some Q&A at the end also. So stick with us, and we really want to be able to answer those questions for you. All right, contraception. Who even needs contraception?
Yeah, so, honestly, those, of course, what most people think of as birth control is just that in the name, is birth control, prevention of pregnancy. So certainly women of reproductive age, and that runs from your teen years all the way up until menopause, there's a chance you could get pregnant. And so women that are trying to prevent pregnancy, of course, that's the number one reason why you think of birth control and contraception. So that's going to be number one. But of course, there are many other benefits, which I'm sure many women out there can attest to, for their birth control or their contraception. So it's not always just for prevention of pregnancy. It can be to help other symptoms that you have, whether it's symptoms of acne, whether it's the mood symptoms that you might get, or your premenstrual symptoms before you get your period. If you have terrible periods that they're crampy, they're heavy, they're irregular, women that just really want some control over their periods. I have a ton of patients that are athletes and really want to know exactly when they're going to get their period, or don't want a period at all. And that's actually okay when you're using birth control. There's much different clinical relevance of not getting a period versus not getting a bleed on birth control. And so some women just want it also for that menstrual control. So many different reasons for contraception.
So I really want to dig into that topic, because that's fantastic about controlling the menstrual cycle. So let's start off with the first broad group of contraceptive methods that my guess is that many women are very familiar with. Many women have used them. And those are the things we really want to focus on, because you've offered a lot of good information as a launching pad. Birth control pills. Very straightforward. In fact, I would suggest that, and I've experienced this in the office myself, when I ask a patient if they're using contraception, I think the brain instantly goes, and naturally so, the brain instantly goes to, am I using birth control pills? So I ask that question, are you using contraception? And they say
Yeah.
no, and then the follow-up is sometimes, well, if you're sexually active, are you maybe using something else for a birth control method? Oh yeah, I use condoms or XYZ. So the most common, I think, experience then comes with birth control
Mhm.
pills. So what are the different types of birth control pills broadly out there that patients can use?
Yeah, so you're right. The birth control pill is definitely still the most common form birth control method used here in the United States. There's some other methods that are creeping up there, but nothing that's coming close yet to pills. A pill is a birth control pill. They come in pill packs, and it's something that you do have to remember to take every single day. And so that is something that, is a deciding factor for a lot of women, is if their lifestyle may prohibit them from remembering to take something every day, depending on if they travel, their work schedule. Sometimes we're just flighty and forgetful. And so maybe this option may not be the best option, but it's something you have to take every day. For most birth control pills, it mimics the normal average menstrual cycle of a 28-day cycle. So you end up taking pills for 28 days, and you're going to get a bleed about every 28 days if you're going to get a bleed at all on a birth control pill. It's hormonal. So when we talk about birth control, there's hormonal methods, and then there's non-hormonal methods. This is a hormonal form of contraception. Most birth control pills are made up of two hormones, estrogen and progesterone. There is a particular pill that is progesterone only for that woman that for any number of reasons cannot take estrogen, which that's why we take a good history on our patients, because there are some women that should not be on estrogen containing birth control. And so there is a progesterone pill as well. But in general, it's a pill. You swallow it. There are some chewable ones, but there are some women that can't swallow pills. It's something that you have to swallow. It's something that you have to remember to take every single day. And in general, it helps with your menstrual cycles. It gives you a nice regular bleed. They can help with acne. They can help with mood symptoms before your period. They can help with the heaviness of a period and the number of days of bleeding. The other thing to note is it's controllable. I have a lot of women that we decide to skip their periods altogether. They're swimmers, they're getting married, for any number of reasons. It's actually easy to manipulate your own period on a birth control pill by skipping the last week of pills, which are hormone-free. So there's a little bit of wiggle room there as far as that 28-day bleed as well.
So I have 3 follow-up questions for you. And the first one
Sure.
is, I think, a fairly common concern and question on the minds of patients. When I'm bleeding, not me personally, because I don't take birth control pills and also don't have menstrual cycles, but if I were asking as a patient, I might ask the question, when I'm bleeding, is that an actual period? What is that?
Right. So, for conversation purposes, you come into the office, and even if you're on a birth control pill, we say, when was your most recent period? But these aren't real periods. These are fake bleeds. They're fake in the sense that your own menstrual cycle is getting completely wiped out with this birth control. And you can think of it, the birth control pill as kind of taking over that menstrual cycle. So what's happening is you're taking these hormones, and the inner lining of your uterus, that's the lining that builds up and sheds every single month with your period. That's the lining is where a baby would implant itself. That's the tissue that is shedding every month. And what's happening, for layman's sake, is that with a birth control pill, those pills you're taking in those first 21 days, those first 3 weeks, it's keeping that lining very, very thin. So what would normally build up and there's a lot to shed, it's really just kind of doing like this. And so there's really not much there to come out, hence a shorter, lighter bleed on a birth control pill, and sometimes no bleed at all. So these aren't real periods. They're what we call withdrawal bleeds, but it sounds kind of funny to come to the office and ask a patient, when was your most recent withdrawal bleed? They're going to look at us like we have 3 heads.
Yeah, right.
So we say periods, but these are not periods at all.
Okay, so while we're on the subject of birth control pills, I've heard these terms thrown around, monophasic, biphasic, triphasic. Is there a difference between any of those, and does it matter?
Yeah, for the most part, it probably doesn't matter. And as far as side effects go, and the side effect profile of most of these birth control pills, all that means mono, di, tri, 1, 2, 3. It's basically the change in the dose of the hormones of the makeup of that pill in your pill pack. And so I tend to usually prescribe monophasic pills. I think there is something to say for keeping women kind of more even keeled of taking the same dose throughout the entire pill pack. A lot of women have heard of the birth control pill orthotricycline. That happens to be a triphasic birth control pill. And if they look at their pill pack, they'll see that there's many different colors of the pills in the pill pack. And that's just the change in the hormones. And it was really, they're made to kind of try to mimic a normal menstrual cycle. Our hormones go up and down throughout our normal menstrual cycle. And so some of these were trying to mimic that a little bit, but I actually do find, as far as some side effects, that some women experience a little bit more side effects the more we change the dose of hormones throughout the pill pack. So I'm usually inclined, especially when starting a woman on a first pill, to keep you on a monophasic, the same dose throughout the entire pill pack.
So that's awesome. Great. So now I've heard of also other types of pills. There are these super duper low dose pills.
Yeah.
Does that mean there's also a super duper high dose pill? And should I, as a patient, as a woman, want to avoid one versus the other?
Sure. So, these lower dose pills are kind of what we call these newer generation pills. Back in the day, so to speak, when pills were first created, they were created with much higher dose of hormones. And it's micrograms. It's really not that much more. I mean, we're talking micrograms of hormones. It's very small doses. But at those levels, that's what inhibited pregnancy. And over time, we realized that we can still give the same efficacy, meaning the same prevention of pregnancy, with lower dose hormones, potentially without giving some side effects, and maybe the safety profile could be a little bit better on lower dose hormones. So in general, I think most of us now prescribe, given that you're going to get the same efficacy of prevention of pregnancy, it's going to be just as effective in prevention of pregnancy, potentially less side effects on lower dose hormones. Why would we prescribe something higher unless someone comes to us with some side effects? The biggest side effect of a lower dose hormone pill is that maybe your uterine lining kind of gets a little unstable. And so you might get spotting here, spotting there, annoying, not dangerous, not worrisome. It's just annoying. And so sometimes these low dose pills can give you a side effect of that unscheduled, erratic bleeding. And some women, believe it or not, even though most of us think of a birth control pill wiping out our periods altogether, giving no bleeding at all, some women, and I completely respect this, are not comfortable not seeing a monthly bleed for any number of reasons. And I get that. And these lower dose pills have a higher chance of wiping out your periods altogether. So for the woman that really needs the comfort of seeing a monthly bleed, sometimes we do have to raise to a higher dose. But again, it's a very small amount of estrogen that we're upping, so micrograms.
So we're getting some really fantastic questions from the viewers on the YouTube channel. One viewer gave me a great segue. So Alexis, I'm going to get right to your question, I promise, because that's a great segue question into our next topic. But Anita wants to know about taking birth control pills and potential effects on her hormones. I'm sorry, my mistake. 1 second. That's not the question she asked. I apologize for misphrasing that. Anita asked the question, will hormonal birth control affect my emotions?
Okay.
An equally good question, probably a better question.
I thought I needed, yeah. So here's the thing, hormonal contraception, there are potential side effects of all these forms of hormonal contraception that, we've only touched on the pill, there's many others. There's potential side effects, and Can your mood be affected? It can. Is it for most women? No. I mean, most women actually do great with any form of contraception. But if you come to us saying that you truly feel that you're more anxious, you're more moody, you're more temperamental, on a birth control pill, it really truly could be that birth control pill. And a lot with these birth control pills is trial and error. And, you know, my line that I tell my patients, if any of my patients are watching, they know is, you know, how you do on one birth control pill can be very different than your best friend on that same exact pill. And how you do on one pill can be very different than how you do on a different pill. And so, yes, the answer, Anita, is yes, your mood can be affected, but for the most part, it's not. And in fact, actually, you know, one of the treatments for a diagnosis called premenstrual dysphoric disorder, which is those mood changes that you get right before you're about to get your period that usually improve once your period comes. And you feel, you just kind of feel awful. You may feel anxious. You may feel emotional. You may feel like you just want to, you know, cry at a Hallmark commercial or scream at your boyfriend for no reason. One of the treatments, one of the treatments happens to be birth control pills. And so for a lot of women, it's actually the opposite, that a lot of times birth control pills can actually help some of those mood symptoms. So, you know, it depends what we're talking about here. And that's why there is a little trial and error involved.
So another great question from one of our YouTube viewers. Back to the basics on birth control pills and going back to my initial question about what's the difference between mono, biphasic, triphasic? Actually, a very great question we should answer. Dee asks us, how does one know which kind of pill pack we have? Mono versus di versus tri?
Yeah. Well, I mean, you can certainly ask your physician that. And we know it based on the name of the birth control pill, because that's, you know, every name is, to us, is mono, bi, or tri. You could also look at the colors in your birth, in the hormonal pills. You can look at the colors, and a lot of times the colors will tell you if there's 3 different colors. Now, we're not talking about the last week of pills, which are usually the non-hormonal pill. That's the week you get your period. You know, we're not talking about those, but we're talking about the other pills in the pill pack. And you can usually tell by looking at the different colors. So the monophasic, you know, for the first 21 pills will all be white, for instance, and then the last week of pills can be different colors because they're non-hormonal. But so you can usually tell based on that, but you can also ask your physician and we can let you know that too.
So we have patients who are on hormonal birth control pills, and I promise, Alexis, I'm getting to your question. We have patients who are on hormonal management of contraception, and they're taking pills, and they're taking those pills orally. And those orally taken pills are then going through their stomach, getting processed in their liver, and their liver's doing all sorts of things with their body's hormones, and those that what we call first pass effect in medicine means it's going through your liver, may be responsible for many of the side effects of birth control pills. So we know, though, that there are hormonal methods that have a good side effect profile that don't go through your liver. So I just wanted to touch on a couple of them, and I'll give you have like carte blanche on this one. Tell me about implants, rings, and patches. Now, people, by the way, is anyone still using the patch? Does anyone even prescribe? There was an old one called Ortho Evra. People still prescribe that?
They do. Ortho Evra is kind of out. These days it's a different brand name called Zulene. Yeah, but yes, the patch has kind of resurfaced in the last couple of years, and I definitely have. You know, I wouldn't say it's one of the more popular forms of contraception that I prescribe, but certainly for some women, it's a very good form of contraception. So if we're moving on from the pill, you know, a lot of women are mentioned in the beginning of the pill that you have to take it around the same time. That's the other important thing. It can't just be you take it at 9 a.m. today and tomorrow you take it at 10 p.m. You know, you're really supposed to take it around the same time every day for it to be the most effective.
And there's a lot of women out there. Within 3 hours. Now, is that the number?
Yeah, I mean, it really should be. Otherwise, you know, we tell patients you should be using backups with condoms for contraception, and consider talking to your, you know, provider about a different form of contraception if you can't. And I certainly have a lot of women that come to me that are just not good at it for, again, any number of reasons, or travel. I mean, right now, obviously no one's traveling, but in general for work, a lot of my patients travel to different time zones, travel internationally. And it's really hard to take it at the same time when you're 8 hours different, out in Europe or wherever. So the ring and the patch are still given by the patient. They're still patient administered. Us physicians do not need to place it for you, but you're not having to take it every single day. So the vaginal ring is placed in the vagina. Some women get a little nervous about it. Can I place it wrong? It's actually very easy to place. Unlike a diaphragm, which is a barrier method that is blocking sperm, this is still hormonal. So you place it in the vagina, it doesn't get lost anywhere. It can't go inside your abdominal cavity. The vagina is a closed entity, and it stays in for 3 weeks. And after 3 weeks, you take it out, and that's your period week, your withdrawal bleed week, and then you start it over again. So you only have to remember, you do have to remember twice a month, but you don't have to remember every day. And it is still hormonal, just like the pill, but very low dose. And patients tolerate it really well. You just have to be comfortable with introducing something vaginally, and not every woman is. And then there's the patch, and the patch is a little sticker. And most of my patients conceal it, in areas that underwear would cover, so either on the front of their pelvis or on their buttocks region. And that is something that you change once a week. And after 3 weeks, it's a patch-free week. You get your period, and then you start the process over. So again, you're not having to remember something every day. You remember it once a week. And so these are good forms of contraception for patients that still want control of their periods and the benefits of helping their periods without having to take something every single day.
Okay, we get a lot of questions in the office, and often they come in the form of email or our interactive video or interactive telephone encounters across the web. We get a lot of questions about the safety and efficacy and ease of use, which are like one of the most important things in contraception: safety, efficacy, and ease of use.
Sure.
About the implant, the rod implant that goes in the arm.
Yeah. Sure. So the brand name that's on the market now is called Nexplanon. It's different. Implants have come a long way. The arm, these are what we call subdermal implants. They go underneath your skin. And we'll talk about implants that go inside your uterus probably to follow. But implants that go underneath your skin, subdermal implants, it's just one rod. It's I describe it to patients. It's about the size of a matchstick. It's not very big. It goes kind of in your skin, right in your upper arm. If I'm just looking at your arm, you can't really tell that you have it there. So it is still concealed, because that actually is something too that we didn't discuss, but a lot of women don't want others to know that they're using birth control for, again, any number of reasons. And I'm sure a lot of women can attest to that. And so you're not having to take something every day. This implant is hormonal. We talked about pills being mainly estrogen and progesterone. This is progesterone only. And it can stay in for 3 years. Nobody knows that you have it. It still helps with your periods. The biggest side effect of this one is that nuisancy bleeding. That's probably the number one side effect of the arm implant, but it really has been proven safe. It's very effective. I mean, this one is over 99% effective. There's no user error, and just of how it's working biologically, it's over 99% effective. It's really effective for prevention of pregnancy. And again, there's always risks with any one of these forms. None of these are without risk. They all have potential risks, but in general, it's been proven very safe. It's been proven effective, and some patients just, they don't know what they would do without their implant. They just love it.
And very easy to place in the office. A very simple procedure, a little local
very
anesthesia,
easy to place.
A small needle, and it's in.
It's tiny. It's a little, yes, you get numbed in that area where it's going to go in. You just feel some pressure. You might have a little bruising in that arm for a few days, but in general, it's very well tolerated. when it comes down to the arm implants versus, intrauterine devices, which we'll talk about, these are all implants in general. And it comes down to patient preference for a lot of it. Just some women get the heebie-jeebies, so to speak, when you talk about something going in their arm versus something going in their uterus. And most women just are okay with one and not the other. Interestingly enough, I find not a lot of women are trying to decide between the two. Most women are just like, oh no, I could not do that, or oh no, I could not do that. It's interesting.
Got it. So for those of you just joining us, welcome to Women's Health Weekly again from the women's health experts at Maiden Lane Medical. And as usual, we are trying to provide you expert health information so that you're not going out on the internet and finding things that may be inaccurate, incorrect, or simply fraudulent. And we really want to do our best as women's health experts here in New York City at Maiden Lane Medical to provide you with the best possible expert information about your health. So I'm going to address Alexis's question, which is a really great one in our segue. Alexis has migraine headaches with Aura. She has migraine headaches with Aura, and she had tried the mini pill, which we both, Dr. Ostrov and I, know really means the progesterone only mini pill. And her headaches got worse. And I know that progesterone in some patients can actually make migraines feel worse. So sometimes the mini pill's okay, and sometimes it's not. But Alexis went back to her neurologist, and her neurologist said no hormonal birth control pills, no hormonal birth control whatsoever. I think a reasonable recommendation by the neurologist, especially if the progesterone-only mini pills are making the headaches worse. Alexis wants to know what other options she has, which is why it's such a great segue to start talking about other options, and perhaps we could launch right into IUDs, potentially? Yeah.
So, that is a great question, and it also brings up the point that there are certain medical contraindications, meaning we shouldn't be prescribing certain forms of birth control depending on your history. So please make sure when you're talking about birth control that your physician knows all of your medical history, medical conditions, family history, but most importantly, your personal history of any medical conditions. And migraines, especially with migraines with Aura, which for those that don't know what that means, and most of the time it's you get these vision changes that happen right before you get your headaches or during your headaches. It indicates to us that maybe you shouldn't be on hormones because it can increase your risk of bad things happening like stroke, which we don't want that to happen. So there are other forms of contraception. They're only completely non-hormonal. If your neurologist is telling you completely non-hormonal, other than barrier methods like condoms, the only non-hormonal option out there is the copper intrauterine device. So IUD, intrauterine device. The copper IUD is our non-hormonal, and then we have hormonal progesterone IUDs. These are devices that are placed in the office. They only take a few minutes to place. I know every patient out there is going to say, I've heard horror stories about IUDs. In general, I promise you, patients do fantastic with the insertions. They really do. I mean, my patients impress me every single day. They do great. It's a little crampy going in. With that said, pain is subjective. Everybody tolerates things differently, but most patients do great. The non-hormonal one can stay in for 10 years. There's no hormones in it whatsoever. So with that said, it's not going to help with any cycle control, but it's going to give you over 99% effectiveness in prevention of pregnancy for 10 years. And it doesn't have to stay in for 10 years. If you're younger thinking, oh my God, 10 years seems like a long time, it's up to 10 years. It certainly can come out sooner. The one potential downside with the non-hormonal copper IUD is some women experience a little worsening of their periods in the sense that they can get a little crampier, so a little more painful, heavier, a little bit longer. So again, a proper history of what are your periods like now, or what were your periods like before birth control, is kind of an important thing for your gynecologist to understand, to know if it's the right method for you. Because for me, it's all about expectations for my patients. I don't want to place the Paragard in you and you hate it. That's not the point. I want you to like it. And if you already have horrible periods in the sense that they're extremely painful, or a history of endometriosis, a pelvic pain condition, maybe I don't want you having a Paragard copper IUD. But we could consider a progesterone IUD, the hormonal IUDs. So to segue into those, depending on the brand, they can stay in anywhere between 3 to 6 years here currently in this country, but potentially you may be able to keep some of them longer. And they secrete progesterone, a hormone that gets secreted. Mainly the effects are on your uterus. You will always absorb a small amount into your bloodstream. So there's potential hormonal side effects, but the main effects are on your uterine lining, which gives you the great benefits of a beautiful, short, light, hopefully non-existent period for most women. And some women don't get any bleeding at all, which is a huge benefit for a lot of women. So that IUD is, better for the woman that really wants to help their periods that can take hormones. There's no estrogen though. So in general, women with migraines with aura can use these progesterone IUDs. I don't specifically know the caller's situation and what her neurologist said, but in general, migraines with aura or contraindications to estrogen, you still can use these progesterone IUDs and use them very well.
Yeah, I agree with that. And there are a lot of clinical situations that we run into where we know that a progesterone-containing IUD, and you pointed out pelvic pain, endometriosis, patients with adenomyosis, which is endometriosis in the lining, in the wall of the uterus or the muscle of the uterus, those patients benefit greatly from the hormone or progesterone-containing IUDs as a primary modality for managing some of those painful conditions. And they're certainly better than birth control pills. And certainly if somebody has an underlying condition such as migraines with aura, then those are really fantastic to use in those patients. Another another YouTube viewer asked us a fantastic question. And I think Anita's asking us the question in regard to IUDs, whether or not the hormonal or non-hormonal IUD is better. And I'm not sure there's a really great answer for that. And I think it's tailored towards an individual's needs and how they feel, and whether or not one of their big interests is pain, endometriosis, decreasing the heaviness of their periods. Is that your general sense of the matter?
Yeah, I mean, in general, it depends how you're defining better, right? So if you're defining better as which one's better at prevention of pregnancy, well, they're actually pretty equal. So they're both going to be over, just like the implant in the arm, they're both going to be over 99% effective in prevention of pregnancy. So as far as better there, they're actually quite equal. As far as better at controlling your periods, well, it depends what we're talking about. If you still want to see your own cycle intervals of, if you get a 28-day cycle or 30-day cycle, well, the copper IUD may be better for that because it's not affecting your cycles. But if you want improvement in the number of days of bleeding, potentially the flow of your cycles, and potentially the cramps, well, then probably the progesterone IUD is better. So it just depends how you specifically are defining better, which for every woman is a different definition. And that's why I truly enjoy having these conversations with my patients in the office, so I understand what their goals are of their form of contraception.
Yeah, it's almost like we have this really deep bench or this really deep menu of options, and there's a combination or one option that suits everybody. Our job is to get that detailed medical history and find out what the patient wants from or needs from a medical standpoint and wants from a lifestyle standpoint, and kind of fit the proper item from the menu, as it would be, into the treatment plan for that patient. And hopefully that's when you sit down with someone like Dr. Ostrov, you get a little bit more of an in-depth, detailed conversation about these things. And that's why you don't want to, I know there are a lot of websites you could go to. You could go online and I know that you can get contraception online. You could do all sorts of online. I think you could email and get birth control pills without even talking to a doctor. These are not great because they're going to miss a lot of important historical items, and they're going to miss that personal connection that you get from your physician or nurse practitioner when you're having a conversation about what's the best type of birth control for me. Another great YouTuber question, just to remind everybody who's joining us, this is Women's Health Weekly from the experts in women's health at Maiden Lane Medical, bringing you expert health information from our team here in New York City. Morgan asks a question: can someone get a copper IUD for the more effective contraception? Now, we know that the utility of an IUD doesn't depend on the use or the way an individual uses is user independent. They're all pretty much equally effective because you can't not use your IUD properly. So
Right.
Morgan wants to know, can I use the IUD for that fantastic contraceptive benefit, but then also take the pill for the cycle control? And my initial thought was, nah, no way. But then I'm thinking,
Right.
she's funny about it. She said, is this even a thing? Well, it could be a thing if you need it to be a thing.
Yeah.
But most people don't need it to be a thing. What do you think about that, Dr. Ostrov?
Yeah, I mean, I think in general, you don't need to be doing both of them. Now, with that said, sometimes for women that are using, say, a progesterone IUD that are experiencing a lot of abnormal bleeding, sometimes we will give them a different hormone to help control some of that irregular bleeding for a short term to see if it helps. But in general, no, I think you should feel comfortable with your one form of contraception. And it's very rare. I don't think I've actually, in the last decade of practicing, that I've ever had to do the copper IUD, a birth control pill on top of a copper IUD. I don't think I've actually ever done that. I guess you could, but I would say that may be a little overkill.
We're going to make an appointment for Morgan and have her have that chat with you. I want to add one more very important part to the conversation. No one at Maiden Lane Medical, neither Dr. Ostrov nor I, get paid to endorse any one particular product. We have absolutely no financial gain to be made by talking about these products. We've named a few by brand name. We have no connections with any of these companies. We have absolutely zero interest. Our primary interest and only interest is offering you the best possible medical information and giving our patients the best possible medical care. All right, so we've talked about a whole lot of different contraceptive options, but we left out two, right? So we left out.
We left out a couple.
Well, you mentioned, we did, right? Two major categories. We left out barrier methods, and is this as straightforward a conversation as I think it is?
Yeah, I mean, so we've left out barrier methods. We actually left out, as far as hormonal, we actually forgot about the shot too.
Did we? That's right. We didn't talk about Depo-Provera.
Yeah. So that is another form of contraception, just so that everybody out there has all their information. It's given in the office, so it's a progesterone hormonal contraceptive that's given in the office once every 3 months. So you have to come see us every 3 months, and it's a shot usually in your arm or in your buttocks region into the muscle. And it's a great form of contraception in the sense that, just like the arm implant and the IUDs, it's over 99% effective. A lot of women lose their periods on this one, so you do have to be okay with that. And you have to come see us every 3 months, which we certainly don't mind, but it depends how, if you can get into the office every 3 months. But it's not something you have to take every day, and it can be really beneficial for a lot of women that, again, their lifestyle just doesn't allow them pills, patches, rings, things like that. So just to touch on that, so we truly have covered all hormonal contraception.
Is there some data?
And then there's
I'm sorry, isn't there some data on use of Depo-Provera in very young women and bone loss, or potentially not being able to achieve your maximum peak bone mineral density in your early 30s?
Yeah, so there was actually, so years ago, we actually would, even when I was training back in residency, we would only keep women on Depo-Provera for a very short period of time because of the effects on bone loss. But actually, research then showed that in otherwise, young, healthy women, actually that bone mass reaccumulates after stopping the Depo-Provera over time. And so we no longer get as concerned about your bone density and the lower bone mass due to Depo-Provera. So we do feel more comfortable keeping patients on it for a long period of time, and even teenagers.
Got it. Excellent. Yeah. All right, so next topic. So we talked do we do barrier method? Oh no, we skipped right to Depo-Provera. Let's talk about, is the conversation about barrier methods as straightforward as I believe it to be?
Yes, it is. Barrier methods in general include there's the male barrier methods and female barrier methods, and condoms is male. And females, we usually think of, although there is a female condom, but we usually think of diaphragms. But diaphragms are actually really hard to come by these days, and they're really difficult to use properly. And so I don't even know the last time I've had a patient actually come in saying that she either A, wants a diaphragm, or B, is still using a diaphragm. They're actually really hard to find for us to prescribe. And in general, you know, there are some diaphragms that are more one size fits all, but they used to be, they have to be sized because they're basically, they're covering your cervix to try to prevent any sperm from going through. But, you know, most of us don't have sizers in the office anymore. And in general, they've kind of gone by the wayside a little bit. They're just really hard to use. And then there's condoms. And I definitely still have a lot of patients that, you know, solely use condoms. And I think our job is just for them to know that, you know, it's certainly not the most highly effective form for prevention of pregnancy. But, you know, another point is, of course, all these forms of contraception, they're not protecting you against sexually transmitted infections. And so, you know, condoms should be used in addition, especially if you're not, you know, in a monogamous sexual relationship. But yeah, it's pretty straightforward as barrier methods. And then there's also permanent sterilization, which I don't know if we're touching on that, but that's the other form of contraception.
We can. We'll go back to barrier methods because we're in New York.
Sure.
And because we're in New York, and because I am, some might say, an older guy, I spent a tremendous amount of time in my 20s, I guess it was my 20s, watching Seinfeld. And I want to know if anyone out there is still sponge-worthy. And if you don't get the sponge-worthy reference, hold on. We're going to put that clip, when we edit this, we're going to put that sponge-worthy clip in. I don't know if we have to get permission from whoever produces, I guess Jerry Seinfeld produces Seinfeld, to use that sponge-worthy clip. But does anyone, the question for you, doctor, does anyone still use the sponge? Spermicidal barrier sponge? No, okay.
No, no, they really don't.
All right. No, it was worth the Seinfeld interlude to ask the question.
You're dating yourself.
Well, you know, you just look at my face and it gets dated instantly. Okay, so got a great question. Alexis asked us a question, a great one. If you do the arm implant, all right, so somebody got this, by the way, somebody in the YouTube viewer group got the sponge-worthy reference and thought it was funny.
Good.
So I'm not that bad, right? So someone asked the question, if you do the arm implant or the shot that's in the muscle, what effects does that have on the muscle mass? And I think I can help kind of answer that fairly quickly. The shot is in the muscle, correct? But the implant's not in the muscle. The implant's actually below the skin, above the muscle. So I think the answer is 0 for 2. There's no effect on muscle mass for any of these. It's just like any other depot type shot that you put and it gets absorbed over time through the vessels that go through the muscles.
That's correct.
One thing that we didn't touch on, abstinence. Yeah.
I mean, abstinence, withdrawal methods, and timing methods. So abstinence, you're absent of intercourse, right? Withdrawal methods, where the male will withdraw the penis from the vagina before he ejaculates. And then the timing, or what a lot of women call the rhythm method, where you're trying to be abstinent, not having intercourse, around your most fertile days. Of course, abstinence is going to be highly effective in prevention of pregnancy.
100%.
100%. You're good. The other two there's a ton of user error with both withdrawal method, as of course I'm sure you can all realize why, and the timing method, just because cycle, you know, a lot of women, first of all, don't understand it. And of course, I open up a calendar and I really try to get my patients to understand what it means to ovulate, and around, you know, looking at their cycles and doing examples and counting the days with them in the office. But a lot of women don't understand it and count wrong. But even if you're counting correctly, there's still a ton of user error with rhythm method, because our cycles aren't always exact. Even if you think they're exact, it may not be exact this month, and you can't necessarily predict that. You ovulate, you release that egg before you get your period, and so you can't always predict that it's going to be exactly 28 days. Maybe it will be 30 days this cycle. Maybe it'll be 24 days this cycle. And so your fertile window changes based on that cycle interval. So there's just a ton of user error, and which is why they're not highly effective at all.
So these are definitely less effective methods than the ones we've been
Oh, yeah.
discussing. Okay, I want to ask a question. My turn. Let's talk about cancer. Because,
Yeah.
and especially in relation to the use of birth control pills,
Yeah.
is there a cancer benefit to using birth control pills, and is there a cancer risk to long-term use of birth control pills?
Sure. So, right, we always think of the bad things that, these hormonal contraceptives can do to us, but what about some of the good things? So what we do know about, birth control pills is actually women that are on them for, several years actually decrease their lifetime risk of ovarian cancer, which that's a big deal because we don't have screening test for ovarian cancer. We have a screening test for cervical cancer, the PAP. We have a screening test for breast cancer, the mammogram. We don't have a screening test for ovarian cancer. And so just by taking the pill, a lot of women say, I've been on the pill since I was 18 in college and now I'm 28. Is this really bad for me? And in general, I tell them, well, you know what you've done to your ovaries? You actually decrease your lifetime risk of ovarian cancer by almost half, which that's a big statistic. So that's a huge benefit.
It's not a small number. It's a huge number.
It's not a
50% decrease in your risk of ovarian cancer is a massive number. There's nothing else that can do that for you.
Correct. So even women that, have family histories of ovarian cancer, and they get actually very nervous about being on a birth control pill because maybe a birth control pill is contributing to it. And of course, it's our job to educate them, know that it's the exact opposite, that this is actually really protective to your ovaries. Same with women, a whole nother conversation, probably not for today's episode, but, the BRCA mutations, the BRCA mutations that put you at a very high lifetime risk of both breast and ovarian cancer, that, it's actually good to be on a birth control pill because we have nothing else to protect those ovaries, and we can talk about how we potentially protect and screen for breast cancer with BRCA mutations, but we don't have great things. We try, but we don't have great things for ovarian cancer screening, at least right now. And so it's actually, there's great benefits to it. And as far as that, I think everyone out there thinks about breast cancer, is there a risk of breast cancer? And, there's nothing out there right now that shows us a direct correlation with birth control pills and breast cancer. And so in general, my answer to all my patients is, listen, I can't tell you that you're at increased risk for breast cancer because you're on a birth control pill. There's a lot of things that came out. I think it was a New York Times article that came out maybe 1 or 2 years ago that scared a lot of women. But it's really important to look at the research behind that. And we certainly don't have any definitive evidence, even close, to say that there's a complete direct correlation between the two. So, and then we can also, there are some, it's even shown like IUDs have a protects for cervical cancer, so there are certainly some great benefits, to these forms of contraception.
So that's why we ask the experts. That's why we ask people like Dr. Ostrov these questions, because we really want to know what the latest research shows us and what type of information we need to digest in order to make great healthcare decisions in correlation with our physicians. We had a guest on last week, Dr. Simran Ratan, who taught me a great phrase, and I'd like to end with this, who taught me a great phrase to refer to our patients, and they're not our patients. They are our health partners. So we have health partners, and we'd like to be your health partners, and we really want to partner with you in offering this information. So this has been Women's Health Weekly. Thank you very much, everyone, for your fantastic questions.
Yeah.
We really appreciate them. We really appreciate your feedback. We really appreciate Dr. Nikole Ostrov from Maiden Lane Medical, and you can reach us at maidenlanemedical.com. And I hope everyone has a really fantastic Memorial Day weekend. Stay safe and healthy, and enjoy.